This morning we're going to have Dr. Mark Iafredi from Tufts talking to us about wound and incision care and treatment. He received his BA from Harvard, MD from Tufts, and has been in vascular surgery at Tufts and New England Medical Center since that time. Is currently medical director of the Wound Care and Hyperbaric Treatment Center. And looking at his background, although his background was, it looks to me like he's got some biochemistry background, but he ought to have some some engineering background in terms of some of the things that he's reported in terms of effects of pressure and stuff. Anyway, as disclosures, he is a clinical trial investigator for Biomet, 3M, Bolton Medical Organogenesis, and Osiris. So without further ado, Dr. Iafredi.
All right, thank you very much. So today, what I'm going to do is provide a little bit of a whirlwind overview. Going to touch on a lot of the main topics that we see from a day-to-day course in the wound center. We'll concentrate a little bit on vascular surgery, causes of venous ulcers, and also give you a glimpse of some of the clinical trials that are moving forward, testing out new and exciting therapies that may be down the road. So these trials listed here are all potential conflicts, but they're all just clinical trial experience, no financial disclosures otherwise. And as I like to think that when you hear hoofbeats, you should be thinking horses, not zebras. So therefore, we'll pay attention to the fundamentals up front and only move off course a little bit. And the fundamental for wound care is that it's actually care of your patient. It's not care of the wound, it's care of the entire patient. And there are a lot of hats that you need to wear in order to appropriately care for these patients and to help them heal. Most of the refractory wound situations involve comorbidities that impair healing. So as I look across the audience here, I would guess that most of you could heal most wounds pretty straightforward, and it's our more debilitated patients that need all the tricks that we have. In terms of the frequency of causes of these refractory wounds and what's seen in wound centers, and by the way, Lowell is fortunate to have in their system a wound care center that's out of the Chelmsford campus, where they deal with these wound care problems on a regular basis. But probably the majority of wound care still happens in private physicians' offices scattered around. So everybody needs some insight. Uniformly across this country, venous and lymphatic diseases are actually the number one cause of slow-to-heal ulcers, with only about 80% of these wounds healing at the end of a full year. So that's a very refractory situation. Diabetic foot ulcers are the ones that I think get the most attention, are the most common cause of wound-related amputations. Good news here is that the major limb amputation rate in the last 20 years in the U.S. has decreased by almost 50%. So we're down to under 100,000 per year. Still a big number, but a lot of progress has been made. And then we get the rest of the series. So vascular diseases, pressure. These days, Medicare has told us that no one should ever have a pressure wound. It's a never event. So there's a lot of energy that's going into preventing them and recovering. And then we get the rest of the group, which tend to be particularly refractory. So we'll move across. And venous disease comes in many categories, from spider veins to ropey varicose veins to this sort of challenging ulcer with swelling and maceration. If we think about venous disease, it's primarily a hemodynamic process at its onset, at least. If you put an IV in a foot vein and measure the pressure, you can see the marked difference in pressure that happens as people exercise and do toe raises in this situation. And here is that tracing. The first part of this tracing is the pressure at the foot. You can see it starts at about almost 100, 90 to 100 in this standing patient. And as they do some toe raises and the calf muscle pumps, it drops the pressure. But in this particular case, where there's bad reflux, it only drops it moderately. If you compress the saphenous vein in this person who has saphenous reflux, you can see a normal-looking tracing with pressure that drops down to 25. And that drop in pressure is normal physiology. And it's this kind of response showing the change when you change the anatomy by eliminating a saphenous vein that improves the hemodynamics in the leg. And you say, all right, so what? Hemodynamics, do they really matter? And here they do. If you look at the pressure that's measured in the foot after one of those toe raise exercises, and you put that in increasing pressure across the bottom, and you compare that to the incidence of an ulceration in the next year, you see really marked worsening, really significant risk of venous ulceration in these patients with venous reflux disease or obstruction, suggesting that addressing this with leg elevation and compression and surgery may well have a lot of benefit. So in your practice, if you see a venous ulcer or varicose veins and you're wondering, is this really venous or not, and is there anything I can do about it? These days, rather than putting IVs in people's feet and pressure measurements and whatnot, we more pay attention just to the anatomy, which is very well delineated with an ultrasound. Ultrasound can give you information about DVTs and incompetent valves and perforating veins, and can help you plan your interventions. Importantly, though, if your question is, are there bad veins that need to be treated in order to heal ulcers, you need to order the proper test. So if you order a venous duplex exam, chances are your lab is just going to do a rule-out DVT study where they're going to put the cursor on and press down and see if this vein, which is visible here, collapses down to nothing as it normally should, to say that there's no clot. That's great if your question is there a DVT? But if your question is there reflux that's a cause of their venous ulcer that needs to be treated, you have to order a venous reflux study. So order the test that you're looking for. If you're looking for a DVT, then just say that on the requisition. It's a common cause of insufficient information. When you do these reflux studies, what you're doing is you're counting on the fact that in a normal situation, blood does not go backwards because it hits these vein valves, and if the vein valves are not functioning, it does. And what you can do is put a cuff at the calf and look up above, and as you squeeze the cuff, you'll see the blood move in an upward direction. You're reflected in blue, and when you relax it, it should come backwards only for about a half a second. And you can measure it and see this backward flow here is very short and limited. That's a normal closure. And here you can see the backward flow persisting for several seconds, which is abnormal. So this is how we identify venous reflux disease and make the diagnosis and then identify the treatment. There are a number of vein areas that you can look at: deep system, superficial system, perforating veins. And when you identify the problem in a superficial system, typically the treatment is eliminating the refluxing superficial vein, and that's okay because there's so much redundancy in the system. So this old-fashioned ligation and stripping procedure still has a limited role. It's effective at eliminating the saphenous vein, can cause quite a bit of bruising. It's down to about 1% of the saphenous veins that are treated these days, as opposed to the much less invasive thermal ablation techniques where a catheter is placed in the saphenous vein, catheter is heated, vein closes, reflux is eliminated, and the problem is well addressed. There are a number of alternatives to those thermal techniques. Thermal techniques, because that catheter is hot, it could hurt. So they require that you instill anesthetic along the course of the vein for patient comfort. If you close the vein with a technique that didn't generate pain by way of that heat, you could skip the injections of the tumescent, which has some advantage. And there are some mechanical chemical techniques, there are some glue techniques. They're newer, they're just now becoming covered by insurance. So that's really the mainstay of routine run-of-the-mill venous disease. Now, in addition to bad veins with reflux, there's also obstruction to flow. And in your patient that doesn't respond quickly to treatment of their superficial reflux, you should think about deep system obstruction. And here it's a little trickier, but if your wounds don't heal, or if you have claudication, meaning you walk for a bit and then have to stop, or you have pain after you're walking, that could either be from venous disease or from arterial disease. Venous disease, the pain is after you stop, as opposed to arterial disease, where you need to stop because of the pain. Helps you sort between the two. But when you have a notion that this is what's going on, there's some investigation that should move in that direction. Yes, sir.
If you're ablating the superficial veins, aren't you just trading Peter to shear fall, whatever, in terms of you're reverting to the deeper system, but doesn't that system also have problems with incontinent valves or not?
So it can. When you do your duplex, it'll give you a view of all of the systems. So your patients that have isolated saphenous vein reflux and ulcers, that accounts for about half of the population, and that half you get really excellent results from just treating the superficial veins. The patients that also have deep system reflux also benefit, but not to the same degree. And the notion there is that the deep veins stuck deep inside the muscle have much better calf pump function. So a bad deep system is better than a bad superficial system. And this would be an example of a patient that you would think maybe has some outflow disease. So motor vehicle crash several years ago. This particular person has a hypercoagulable state, has an IVC filter that was placed and not removed, history of a blood clot, and on exam has very significant edema, hyperpigmentation, distended veins, and ulcers that were refractory. So not a subtle case. In this person, when the ultrasound probe is placed on the femoral vein and you ask them to take nice deep breaths, you should see very significant respiratory variation in that flow, because the intrathoracic pressure is reflected on the vein flow, and here it's quite muted. So our standard ultrasound gave us a suggestion that there's a problem there. So we went ahead and did a venogram, and here you can see a filter in place with flow in the vena cava above the filter, but nothing below the filter. Here you can see the filter in cross-section with the vena cava completely collapsed around it. And when a venogram was done and there was an injection into the femoral vein, there's no flow at all in the iliac vein system in this particular case. So the thought was initially, maybe we should take out the filter and then we can open up the system. Unfortunately, this filter couldn't be removed. Most of them can with an endovascular approach. But despite that, we're able to get across the blockage, balloon it open, place a stent, allow for outflow. There's pretty good collateralization across the pelvis from one side to the other. So opening up this one route of egress for blood dramatically reduced his venous pressure, fixed the edema, healed his ulcers on both sides, and has been quite durable to this point. So that's reflux disease and that's obstructive disease. And until recently, there was no real consensus about how to manage this venous disease, in particular in relation to ulcers, until the American Venous Forum and Society of Vascular Surgery released this consensus statement. Tom O'Donnell, the lead author on that, was our former chairman and president of the hospital down at Tufts. led the process. And I'm just going to point out a couple of highlights that maybe go against what people generally think. So first off, there was a recommendation against routine wound cultures of these drippy, superficial wounds that are not necessarily infected at the time you do it. The data is at best confusing and potentially a problem because people feel like they need to treat these antibiotics on the surface. You will always get a positive culture if you culture a venous wound. So avoid that. Do get the proper test, with the ultrasound being the workhorse test, and the venous imaging with CT or MR or catheter-based procedures when your question is outflow obstruction. Debridement to remove all of the crud that can be on these wounds is a repetitively necessary component of treatment. Avoid systemic antibiotics. Again, if you're not culturing, then you're less likely to get sucked into systemic antibiotics for wounds that aren't infected. And also, there's a recommendation against topical antimicrobials. So there's a general feeling that, well, let me just put something on this wound because it looks a little goopy. And there's silver, and there's iodine, and there's gentamicin, and all sorts of things you can put on the wounds. But again, let's try not to change the flora in our patients unnecessarily unless they're actually infected. Compression is a mainstay of therapy always. There are a lot of different ways to accomplish the compression. It does improve healing rates. It does improve recurrence rates even after you're healed. There are a bunch of different ways to do that. If you're doing it with bandaging wraps, the data would suggest the more layers to that wrap, the more effective. So there are prospective randomized trials saying that 3-layer wraps are better than, or 4-layer wraps are better than 3 layers. Although there are some newer products now that call that into question a little bit. And do make sure that you check for arterial disease. Now, the presence of arterial disease, the notion here is if you have bad inflow through your arteries, you don't want to put on a tight wrap to treat their edema or their venous disease, because you might not perfuse the tissue and you might cause a wound. That makes sense. Unfortunately, it has been propagated so widely that it is used too much as a reason not to do compression. A lot of protocols in various societies will say that you shouldn't do it with an ankle brachial index less than 0.9 or 0.8. The data actually says that down to an ankle brachial index of 0.5, so that means half the normal arterial flow is enough to support the use of these compression garments. And it actually shows that the perfusion, if you do perfusion measurements in the foot, improves in these patients with moderate ischemia because you're eliminating all that edema. So don't be too afraid, but do check. So someone with no Doppler signals in their foot, for instance, you wouldn't put a heavy compression on. But for moderate disease, you could. Now, one of the comments that you'll hear in a lot of practices is, well, I don't ever need to fix anybody's veins. All I ever need to do is put on compression garments, and they will heal, and they will be fine. I heal all ulcers immediately with use of compression. There's never reason to do venous surgery. And it's just not true. So first off, I started by telling you that only 80% of venous leg ulcers are healed at a year when you look at any of the big actual published series. And secondly, in this nice study called the ESCAR trial, which randomized patients to compression plus superficial surgery, which at that time was vein stripping, because this is now a 15-year-old study, versus compression alone, they saw that after the patients healed, the recurrence rates were almost twice as high for the patients who had compression alone. So definitely a role for venous surgery in preventing recurrence. There actually was just, and this was a Lancet publication, there was just a follow-up study done with a new prospective randomized trial out of Europe that was orally presented 2 weeks ago that also showed a significant reduction in time to heal. This initial trial didn't. So you shouldn't wait until they're healed. You should try to look into their causes of their disease and fix the cause if it's fixable. And this was also supported, this conclusion was supported in meta-analysis of all the smaller studies as well. Well, what about cost? So surgery is relatively expensive. Can our system afford to treat these patients with venous ulcers? Wouldn't it be economically better just to put them all in stockings and send them on their way? So at Tufts, we actually looked at the cost of treating our own patients. And here we looked at all costs. So office professional costs, facility costs, admission to the hospital, procedure costs, DNA costs, everything associated with the care of venous disease and ulcer in our patient population. And we followed it forward over a few years. And in the first year, we found that indeed it was more expensive to add a surgical procedure to just plain old compression alone. However, over time, when we looked out to 3 years, we had a 93% healing rate versus a 66% healing rate in the patients with surgery versus compression alone, and lower recurrence rates as well. And that translated over here to a significant reduction. So this is statistically significant reduction in cost, not a big reduction, but costs less, works better, meets the criteria. So your patients had better quality of life, they had fewer ulcers, they had fewer operations if they got their procedures early. Now in terms of the compression piece, none of that which I just said was meant to imply that you shouldn't do compression, because compression is really the best way to go. It can sometimes be difficult. There are many different ways to accomplish it. This one slide is a whole lecture in and of itself, but basically moving through wraps, which have to be applied by nursing staff generally, into compression stockings, which are quite effective actually if the patient can get them on, to a Velcro-assisted device that also is very effective and most patients can go on, costs about twice what a stocking costs. Versus pneumatic compression, which your most refractory patients can just have living at home with them. They put it on for an hour, 2 or 3 times a day while they're sitting watching TV, and it really helps reduce their overall girth. So that's what I'm going to say about venous disease for now. This is a classic figure of lymphedema. The erythematous legs at baseline with flakiness, hump on the dorsum of the foot. This can be very, very challenging situations. Here, compression is really the mainstay. Lymph scintigraphy, in which nuclear tracers are injected into the foot, can demonstrate the absence of the lymphatic channels in the thigh. As in the U.S., there really is no surgical intervention that's accepted. We're not doing a lot of lymph scintigraphy these days. Instead, we more pursue everything else. So identify the venous disease that might look like lymphedema, identify the cardiac and renal and hepatic issues that could impersonate it. But it can be visualized, and there's some newer technologies that are pretty cool. So this is a technology that uses indocyanine green and a handheld probe, similar to the SPY device that's used to look for perfusion during flap procedures. And here you can actually see the lymphatic channels, and in real time you can see these vessels peristalse as they move the tracer out of the leg. So lymphedema then, again, big challenge. Compression is the mainstay of therapy. There are some surgical procedures that try to move the flow from lymph nodes and lymphatics into veins, and nothing that's been adopted in the U.S. Some promising information from Eastern Europe at this time. Now, on the arterial side of things, this I think is what people think of more commonly, frequently together with diabetic ulcers. There's about a 50% overlap in patients with critical limb ischemia having diabetes. Renal disease makes it challenging as well. The toolbox that we have to address revascularization is really pretty full at this point. The number of procedures has been going up and up and up, and becoming more and more catheter-based and less surgical as we come up with new tricks to try to get the blood from the heart to the toes. One of the big questions that is in the field is, so you've got this bypass operation that's kind of invasive and it's got a 50-year track record, so we know sort of how that works. How about all these new procedures that are less invasive? Are they really better? This basal trial that was published now 8 years ago was a prospective randomized trial in which patients with critical limb ischemia were randomized either starting by having a bypass or starting by having a catheter-based procedure, or at least randomizing to those groups to try to answer the question, who does better, surgery first or catheter first? The study at 6-month follow-up showed 21% of the bypass patients received amputations and 26% of the angioplasty patients needed amputation, and that was not statistically significant. So the initial report said, hey, this is great. It doesn't look like it's much worse to have an angioplasty, so we should do that. The study initially had some problems because a number of the patients didn't get their assigned intervention initially. So half the patients that were randomized to angioplasty actually got a bypass, and a third of the patients randomized to bypass got an angioplasty first. So there was a little bit of problem with buy-in of the patients and the physicians into the trial, and it was reported as an intention to treat analysis. But they carried on, they did good follow-up, and they reported 2-year results. But at 2 years, they actually saw that the overall survival and the amputation-free survival were both better in the surgical bypass group than they were in the angioplasty group. When they looked overall, the results were markedly better for the open surgical group than the endovascular group. So the take-home message was that if one procedure is obviously anatomically much better than the other, you should do it. But if you have anatomical anatomy that's good with either approach, and you think the patient has reasonable long-term life expectancy, and here that's more than 2 years, then they do better with bypass than they do with endovascular. That being said, it hasn't changed that incline that we've seen on the adoption rate as patients are asking for less invasive procedures and I think not being fully informed. There is a U.S. study that's ongoing now that's essentially repeating this with an enrollment target of 3,000 patients as opposed to that 500 that we saw initially. So we'll have better data in about 2 or 3 years to help figure that out. One of the other challenges is that while bypass hasn't really changed at all, so the data there is pretty reliable, the endovascular procedures keep changing so fast that by the end of the trial, you may have fancier stents, like these drug-eluting stents that have been used commonly in the coronaries for 15 years. They've just made it into the peripheral environment in the last 2. So the bar keeps moving there. Now, what do you do if your patient doesn't have options for revascularization? So if you can't go through it with an endovascular approach, and you can't go around it with a bypass, what else can you do? Turns out there there are some pretty simple things you can do. And this device is intermittent pneumatic compression device. Squeezes first at the calf and then at the thigh, and does so at high pressure, as opposed to the DVT compression pumps that are cycling slowly at low pressure. This cycles shorter pulses at higher pressure, and it improves perfusion in the limb. You can measure increased flow rates across the popliteal artery in patients with patent popliteal arteries, and in some small, not very well done studies, there's been some very encouraging results suggesting marked improvement in amputation risk. And this is a device that I use pretty routinely in those patients that have unreconstructible disease. Of course, you want to protect your patients, so your diabetic patient with a pressure wound, you want to take the pressure off with the appropriate devices. And, of course, you need to pay attention to the medical management, as I started with. Single antiplatelet therapy now is the standard. And this is a bit of a pendulum thing, where a few years ago everybody was escalated to double antiplatelet therapy for severe peripheral vascular disease, and we found that the cumulative bleeding risks were pretty significant in the cardiovascular population. So other than when there are drug-eluting stents, the current recommendation is single antiplatelet therapy. The other thing that's key here is our statins. Statins are probably the single thing that you can do that has the biggest impact on your patient's 5-year survival if they have critical limb ischemia. In New England, in our registry set that we have amongst, I think there are 40 hospitals that report their vascular data into the New England registry. It's now national registry. The absence of statin increased mortality at 5 years by 25% in our patient population. So it's really key. And the LDL goal is less than 70, according to the AHA guidelines for patients with peripheral vascular disease. And everybody benefits from statins, no matter how good their LDL baseline is. It's just a matter of what the dose is that we start them at. So moving into the wound world a bit here. So what are our dressings supposed to do? Well, they have fairly consistent goals. So we want to protect our wound, maintain a moist, warm environment. We don't want too much exudation to be macerating the surrounding skin. We want to control bioburden, and we want the wounds to heal. Now, one of the keys to healing is that before any wound can heal, you have to get rid of that debris on the surface. And it's amazing how much debris will accumulate from various reasons. This can be cleaned off and should be cleaned off effectively with some steel, typically a scalpel or a curette during your clinic visits. But between clinic visits, you want a wound care product that will help remove this, or in your patients who won't let you do appropriate debriding. There's only one product on the market that actually is enzymatic at this point. Santyl is the trade name. It's a collagenase. It is effective at breaking down the collagen cross-linking and speeding healing. The newest data says that using this product from presentation to complete healing is actually quite effective compared to most controls. But basically any of the moist wound gels, whether just a hydrogel or a honey-containing product, they all create a hydrophobic environment. The high sugar in the meta-honey actually prevents bacteria growth because it's such a high osmolarity with that. But these things are all effective treatments. We talked about the antimicrobial options, and I told you shouldn't put it on every wound, but you can use and should use antimicrobial dressings in wounds that have a high bioburden, at least temporarily while they have that. Silver is active against the resistant organisms for the most part currently. Interestingly, you only need 1 part per million to get some kill against bacteria. And the question is, what's the right amount? Now, every one of these manufacturers will tell you that they have just the right amount. And you can see a 100-fold difference between the lowest concentration and the highest concentration. And there are essentially no head-to-head trials of any of these silver products, so we're left kind of wondering. The simple products that you'll see used a ton are these foam products. They're cyoelastic or polyurethane foams. They're permeable. They let the gas escape. They help wick some of the moisture away from the wounds. Companies each have proprietary technologies that they trademark some commonly used word like wicking or convection or something, and they're all designed to move the fluid straight up so that it doesn't macerate the side, but keeps a nice moist wound environment where the healing is supposed to happen. None of them have actually figured it out all that well, and there's room for improvement there. When wounds are highly exudative, that's when these cloth-like products tend to be used. So there are calcium alginates, which initially were all derived from seaweed, which is super absorbent to start with. Now there are a bunch of synthetic products as well as those natural occurring fibers, and these are used again at your discretion. There's a lot of financial drivers in terms of getting the best deal for your wound center to try to keep costs under wraps. And then we get some products that are a little more sophisticated in terms of the proposed mechanisms of actions. Collagen has been used in various forms, and there's a lot of reason to think that collagen could be helpful. There's a notion that if you lay down the collagen matrix, that those fibers will set up a spot in which fibroblasts can anchor and create cell growth on it. And I don't think that's ever actually been seen in patients, but it is true that the matrix metalloproteinases do bind to these collagens quite nicely, and that's probably the more relevant factor of cutting down that big inflammatory part of the cascade. And here we have, modest but statistically significant benefit. Now, if we get to more advanced products, so this Apligraf product was actually created by a local company, Organogenesis, out of Canton, Massachusetts. This was the first of the cellular therapies directed toward wound care. And Apligraf is actually a cultured cellular product. The cells that they use in this actually were derived from circumcisions that were done at Tufts back in the day. Unfortunately, none of the money stayed at Tufts, went out to Canton. But this bilayered cellular product can be placed on a wound with the notion that these cells are setting up the matrix that you need to grow in your own cells and heal the wounds. And they did trials in diabetic foot wounds showing statistically significant difference, and they did data that showed decreased amputation risk in these diabetics. They also did trials that showed decreased time to healing in venous stasis ulcers. So this was the first of the FDA-approved products at this high-end, complicated situation, and they're still in the market. However, those cells clearly won't live in the host. They're just setting up the environment. So a number of folks thought, well, maybe we can get the cellular benefit without using the live active cultures, because it's sort of a nuisance to have to transport a petri dish that has a short shelf life. Couldn't we dry something out that has those factors? And a product called Oasis, which is a collagen product, it's actually derived from porcine submucosa, is in fact biologically active. It looks like a piece of parchment paper that you can place on a wound, and you can repeat these treatments every week or two. And this study in venous patients did have statistically significant improvement in healing rates. So based on those first two products and a few others in the same category, FDA was bringing products on one at a time, saying, you test it against venous patients and we'll give you an indication to say that you can sell it for venous patients, and insurance companies are covering it. And then about 2 years ago, they had a complete change in the way they approve stuff at the FDA in the wound healing world, and basically said that based on other similar products, like they do for devices, you can just come up with something that's essentially a good idea with not too much data, and we will give you a blanket approval for any old kind of wound. We're not going to parse the different wound types like they used to. And when that bar was just lowered, all sorts of stuff came into the market in the last 2 years. And all of these products have data to support them. None of them have comparative head-to-head data, and none of them are specific to one wound type or another at this point. But what we're seeing now is actually a proliferation of products, in particular, that come from placenta, from amniotic membranes and placenta. And here you see three of the products straight away. These are dehydrated. There's nothing in these particular products that needs to be kept alive in a petri dish. There are similar products that come frozen, but this is really all about setting up the environment. These cells don't become part of you, but they all do have significant clinical benefit, and they also come with significant cost. One of the pieces of these products range from about $500 to $5,000 per application, and CMS regulations allow 10 or more applications per year for these refractory wounds. So I think it's incumbent on us to try to be good stewards of these products. It's cost effective to heal wounds quickly, but you need to be seeing progress and select your patients appropriately. Negative pressure wound therapy, skipping across here, or VAC, is clearly shown in many trials to improve the rate of healing in a variety of wounds. This is one of the nicer studies published now a decade ago. VAC versus standard of care therapy in diabetic foot wounds, showing significant reduction in time to heal. Multiple benefits in terms of control of the exudate, the reducing infection risk, and improving blood flow based on the stimulation at the base of the wound. There's an interaction that happens as the pressure creates shear on the basement cells that improves vascularity. So since it's reimbursed and effective, there are now a bunch of products in the market. So there are many vendors that have created some competitive pressure. One of the tools that your wound center here at Lowell has is the use of hyperbaric oxygen therapy, and this is our chamber down at Tufts, but you have the same ones here. Now, hyperbaric oxygen is not useful in just plain old ischemic chronic wounds, but it does have a lot of uses, and in particular, acute ischemia, like from a crush or a flap that's failing, or a severe diabetic wound that isn't responding to conventional therapy, or interestingly, radiation-induced injuries are really the areas that hyperbarics works the best. Now, it's not hyperbariatric, it's hyperbaric. Okay, so that's a comment that we've heard. And why should it help? So, like everything, there's good and there's bad in what we see. So, I've got red and green going on. So, when exposed to high-level oxygen, you will have a compensatory reduction in your hematocrit. It's kind of the opposite of why athletes train in Denver to get their crit up. But that's a pretty minimal change, 1 or 2 points after 2 months of therapy on average. On the other hand, you also get decreased platelet aggregation, so you get less microcoagulation or microthromboses. Your red cells become more deformable, so they can pass through stenoses more effectively. Probably one of the most important things is the oxidative burst that's involved in the kill that happens with your neutrophils. So all that stuff in your peroxisomes is based on hyperoxygenation and oxygen-free radicals, and you can increase the oxidative capacity of these neutrophils by 10 to 15-fold. So with the same white count, you get much better kill of your bacteria. Your hemoglobin is fully saturated, so you get better oxygen delivery, but your serum is also saturated. So the amount of oxygen that you can deliver is tremendous. And there's upregulation of angiogenesis, which is probably one of the biggest keys to oxygen therapy. And it's a little counterintuitive to why that would happen, but we'll talk about that a little bit later. Vasoconstriction does happen as a compensatory mechanism in normal vessels, which you might think is bad, but on the other hand, one of the indications for this therapy is treatment of crush injuries, and those patients tend to be your younger, healthier patients, and it cuts down on the edema that would normally occur. So it's probably more good than bad from that range. And in addition to your increased killing capacity of your polys, you get direct alpha toxin inhibition with C. perfringens. So your gas-forming, aggressive infections are treated both by killing the bacteria and by neutralizing the alpha toxin. And then in terms of the growth in the bed of the wound, there are multiple areas of positive influence. When we look at what happens in the wound and how these cells differentiate, it's actually not the cells in the base of the wound that have the greatest capacity to promote healing, but it's actually your progenitor cells that get there remotely, that reside primarily in your bone marrow and then are called for and move to the site of injury. And that's where we see the difference. So we have a number of factors that are released from the local site of injury that impact the bone marrow that cause these endothelial progenitor cells to move to the site of injury. Hypoxia, this hypoxia-inducible factor, does downregulate vascular endothelial growth factor a little bit, but the impact of the hyperbaric oxygen on the bone marrow and kicking these stem cells out of the bone marrow and getting them into the circulation very much overwhelms that effect. For instance, here we can see tissue in the mandible that has been radiated. And what you may notice is this kind of uniform glassy appearance and the lack of blood vessels in this tissue. This is tissue that is at very high risk for failure to heal if exposed to surgery. If the same patient, and this is tissue from the same patient after treatment with hyperbaric oxygen, can grow new blood vessels in that area of ischemic tissue, you can very much improve the outlook for healing when you operate in that field. And this is after 20 sessions of hyperbaric oxygen. And if you look at the oxygen concentration in those tissues, here we've got normal levels breathing room air for most of us in here, hovering around 100. And here we have a patient who has been radiated, and has very poor tissue concentration of oxygen of 25 or so, and this is an actual patient. Numbers above 60 are considered to heal generally pretty well, and above 40 considered to heal very poorly generally. And this x-axis here is number of sessions, and generally it's Monday through Friday, so 20 sessions means 4 weeks. You can see a very dramatic increase in the oxygenation of those tissues, and importantly, that's a durable change. So you do this treatment to someone, and for years to come, that vascularity is sustained. These treatments generally take about 2 hours. As I said, most places do them Monday through Friday. Typical patients are treated for 20 to 40 sessions, so it's a big commitment on the patient and the facility. And we assess patients as they move along, and only continuing treatment if you're seeing improvement. Now, one of the big questions that always comes up is if it's going to grow your skin and your blood vessels, is it going to grow tumors? And the answer to that is not as far as we can tell, and people have been looking at that question for 40 years. There's no data to suggest that that's a risk at all. Even in patients who have known cancer, there's no data to suggest that the hyperbarics make it any worse. So what we might see in our wound centers these days is someone like this. Young diabetic man comes in, very febrile, high leukocytosis, blood sugar's out of control, looking sick, positive blood cultures, a foot that doesn't look so terrible, except there's a wound there that has gas gangrene. This patient needs surgical therapy, but also received hyperbaric oxygen. Here we're 4 days post-op. Back therapy, hyperbaric oxygen therapy, we're at a week out. And now, at the end of a week, we've got a limb that's clearly on its way to be salvaged. Here's 2 weeks. The anterior wound is closed. The foot is closed. He didn't even lose his toe. And this is somebody who was on the verge of being dead coming into this system. Osteomyelitis that's refractory to conventional therapy is another good target for the situation. Another diabetic, poor blood sugar control, failed a couple of cycles of antibiotics, 6 weeks each, over the course of a year. This wound just wouldn't heal, and that Q-tip extends right down to the calcaneus. Here you can see bone destruction on your plain film for your osteomyelitis. Multimodality therapy. We trim off the back of the heel bone, so this is a partial calcanectomy. Close them up, looks terrible, but in 2 weeks it's completely healed in this case. Again, surgery, oxygen therapy as a combined approach. Another gas gangrene case. The tip of the iceberg, as you say. So here, this toe is actually clearly on its way out. All sorts of air in the subcutaneous tissue. A sick patient goes to the OR to have the source eliminated, and 3 weeks post-op, negative pressure therapy, oxygen therapy, essentially healed. Another similar case, you might see this kind of foot coming in the ER. Looks like someone who maybe would be going straight to a guillotine amputation if he was a little bit sicker. But with surgical debridement, hyperbaric oxygen therapies for a couple months, fully healed, no loss of any tissue, and minimal hospitalization. We talked about the radiation injury. So this is a person who is 44 years old now, but had radiation injury when they were 9, treatment of an astrocytoma. Now the trick with radiation soft tissue injury and the injury to the vascularity is that it's the gift that keeps on giving. It never gets better, it always gets worse. So the further you are out from your exposure, the worse your vascularity is going to be. This fellow developed a wound or lady on the top of her head that was making zero progress with wound care and debridement. And over the course of 2 months with hyperbaric oxygen therapy, healed up this wound that had been present for a year with nothing else fancy. So how about some high-tech stuff in our last couple of minutes here? We've got to balance hope and data and evidence, and for the most part, the wounds are winning, but we keep trying. So an area that people have been pushing for years has been growth factors, vascular endothelial growth factors, fibroblast growth factor. There's a common theme that initial studies always look great and follow-up studies always shoot them down. So this fibroblast growth factor in a trial called Talisman, really encouraging initial trials, shot down in all future trials. Jeff Isner is a Tufts professor, was former investigator. He's the first guy to really push this VEGF forward 25 years ago. Unfortunately, it hasn't worked out. Platelets get a lot of press. They keep cycling from year to year because they're just loaded with various growth factors. There are a number of trials that suggest that there's benefit in wound healing. None of them have been sufficiently well done to carry any weight, but it is a product that's currently available. You select the patient's own platelets, inject them into the area of interest, and those are all under clinical trials. There is a product that's commercially available called Regranex, which is commercially produced. Has some issues that we could talk about later. I'm going to just kind of bring this forward a little bit. Gene therapy makes a lot of sense. Why would you just want to put it in for the day or two that the product is present when this is a chronic issue for patients? So how about if you just change the whole genetic profile and carry some extra VEGF and transfect it to the sites? Again, excellent preliminary data, completely shot down by larger prospective randomized trials. So that's kind of stuck in the water. And I'm going to just bring you on. So angiogenesis is an area that I have a lot of hope for. It's super complicated in terms of the parts that you might want to move, but these endothelial progenitor cells coming from bone marrow seem like something that might be a target, since your patients don't have enough of it or they're not converting well enough. Maybe we can augment this system, this biofeedback system, to take those active cells and move them to where we need them. There are a couple of products that let us isolate those point of service from a bone marrow aspiration in the operating room, and 20 minutes later inject them into the leg. There's some clinical trials that I'm involved with that are looking at it. It's sort of the same deal. Preliminary studies look very encouraging in terms of pain relief and amputation risk. This is from our pilot study. Didn't quite reach statistical significance at a p of 0.09, but that's ongoing. A number of trials from a number of centers around the world that are looking at it. If you put them together in a poor man's meta-analysis, it looks like there's significant difference in limb salvage, but the studies are so dissimilar one to the next, it's really not fair to do this, so we're going to need to wait for some bigger studies to come out. The most recent one, we actually just enrolled the first patient in the U.S. 3 weeks ago in this clinical trial using live placental-derived cells to inject into the leg of someone with critical limb ischemia. These placental cells are known to increase angiogenesis, be an immunomodulator, and help with muscle regeneration. So time will tell on that. So got a lot of balls in the air, a lot of balancing that needs to be done, and it's complicated. So thank you very much.
How do you evaluate patients, just patients like non-ambulatory